Good morning, good afternoon, and good evening, esteemed speakers and participants from across the globe. I welcome you again to yet another IPA webinar on oncological emergencies for pediatricians by the IPA program area on oncological pediatricians. Now coming to instructions, if you have questions for the speaker, kindly put them in the Q&A feature. To receive the certificate of attendance, participants must attend the entire duration of the webinar and complete the feedback form. The feedback form will be available once the webinar ends through a give feedback option that will appear upon closing the webinar session on your screen. Please note that the Zoom closed captions are generated by AI and there may be instances where the translations are incorrect or misleading. We appreciate your understanding in that. Now I would welcome Dr. Ekanu Mekure, who is the moderator for the session. Dr. Ekanu Kekure is a professor of pediatrics at the University of Lagos and consultant pediatric cardiologist at Lagos University Teaching Hospital with over 20 years of experience. A fellow of the West African College of Physicians, she holds an MD from the National Postgraduate Medical College of Nigeria. She is the president of the Pediatric Association of Nigeria and serves on key international pediatric association committees, leading national immunization advocacy and advancing child health in Nigeria. Over to you, Dr. Ekanu.
Thank you very much for the introduction. One quick correction. The immediate past president of Pediatric Association of Nigeria. 3 weeks ago, we did have an election, and our new president is Dr. Petronila Tabansi. I want to appreciate the presence of the IPA president in our midst and the moderator and all speakers. Good day, distinguished colleagues and partners in child health. On behalf of International Pediatric Association, IPA, it is my great honor to welcome you to this special webinar on oncological emergencies for pediatricians held in recognition of the International Childhood Cancer Day 2026. Today, we join a global community united by a shared commitment, ensuring that every child, no matter where they are born, has the best possible chance, not only to survive, but to thrive. Childhood cancer remains one of the leading causes of mortality in children worldwide. And we know that outcomes can be dramatically improved with early recognition, timely referral, and prompt management, especially in the case of oncological emergencies. Conditions such as tumor lysis syndrome, spinal cord compression, and so on, febrile neutropenia, raised intracranial pressure, they are all things that demand swift and informed action. And in many settings, the pediatrician is usually the first and the most crucial link in that chain of survival. This webinar is therefore designed to strengthen that link. Whether you're practicing in a tertiary center or a lower center, what is important is the ability to recognize the red flags and initiate immediate management, for this can mean a big difference between life and death. Today's session aims to improve practical evidence-informed guidance that we can apply in our daily practice. As we mark this International Childhood Cancer Day, let us all reflect on equity, where survival rates for childhood cancer exceeds 80% in many high-income countries, and yet in some low and middle-income countries, it remains far lower than expected. Bridging this gap is not only a clinical responsibility, it's a moral imperative. The IPA stands firmly committed to capacity building, collaboration, and advocacy to improve pediatric cancer outcomes globally. By coming together to share knowledge and strengthen our skills, we move a step closer to a world where no child dies from a treatable cancer. Once again, thank you very much to the team that have dedicated their time to this important topic and for the extraordinary work they do in their different places. You are all welcome, and I know you are going to have quite an educative time. Thank you.
On behalf of IPA, I would like to invite Professor Joseph Haddad, President of International Pediatric Association, for his opening remarks. Professor Haddad is a professor of neonatology and the president of the International Pediatric Association currently. He's a distinguished pediatric leader dedicated to improving neonatal and child health globally through advocacy, education, and international collaboration. Over to you, Professor Haddad.
Good day to everyone. And without further delay, I think that Ekanem has done a very good introduction. I will only emphasize on the role of IPA in this group of oncology, program of oncology. I wish to congratulate you all, and I wish also to congratulate the speakers, moderators here, and without further delay, let's move because we are a little bit on.
Thank you, Professor Haddad. So we go on to the next part of the session, which is the educational webinar for today, which we have decided on the topic of oncological emergencies. So this session will be divided into two parts. Initially, there will be a 15 minutes overview on oncological emergencies. And after this, it will be a panel discussion. So I'll be discussing the oncological emergency section, and the panel will be by the esteemed panelists and the moderator who has joined the call. We'll be introducing them after this talk. So what are oncological emergencies? Like Professor Ekanam just discussed, oncological emergencies are those emergencies which need to be diagnosed quickly. And if we don't pick them up, they contribute to a significant cause of mortality in these children. So if you compare outcomes of children with cancer in different countries, there is a lot of inequity and there's a lot of disparity, which a percentage of which could be because of oncological emergencies as well. Many a times in our earlier webinar, we discussed early diagnosis of childhood cancer and why it is important to pick these children up early. And one of the reasons why oncological emergencies do not fare so well in resource poor setting is that there is very less awareness regarding these emergencies, and they are often managed as some other condition. And nobody thinks of cancer when a child presents with a seizure or a headache or a vomiting, for example, and they just get missed. And by the time the diagnosis happens, it is often too late. So these are emergencies which are acute, potentially life-threatening events. And if we do not anticipate quickly or treat them effectively, they may result in permanent morbidity or mortality. Morbidity, for example, I think in one of the later panels, you will discuss here spinal cord compression, patients who come with paraplegia. So if we don't act immediately, it can result in lifelong neurological deficits, and which is something we do not want for any of our patients. So we'll divide oncological emergencies into three sections: metabolic and endocrine disturbances, space-occupying lesions, and third is pancytopenia. Metabolic and endocrine disturbances result from what is being from the tumor per se. The tumor, it can be because of lysis of the mass or the tumor cells, which results in what is called tumor lysis, or it could be from the cells being high, or it could be a endocrine issue, it could be a metabolic issue which comes out from say, for example, hypercalcemia, etc., which can be straight away from the tumor secreting it. So these are issues which can be directly related at presentation, or it could be secondary to therapy as well. Second is conditions where there is a mass and that it's causing a mass effect. For example, if it's in the mediastina, it would cause superior mediastinal syndrome. If it is in the brain, it can cause raised intracranial pressure. And finally, because counts are low in many malignancies, especially leukemia lymphomas, this can result in infection, it can result in hemorrhage, and it can result in anemia. So these are the oncological emergencies that we commonly encounter, and I have listed out in three different headings: mechanical, metabolic, and infectious. And we'll see just small snippets of how it does in this current talk, and this will be followed by a more detailed panel discussion. So mechanical, if it's in the chest, it's superior mediastinal syndrome. It could be massive pleural effusion, massive pericardial effusion also causing features like tamponade. Patients presenting with spinal cord compression, raised intracranial pressure. Under metabolic tumor lysis, you have hyperuricemia, hypercalcemia, hyperphosphatemia, and hypocalcemia. It could be hypercalcemia per se as a metabolic disorder. It's not tumor lysis, but it is a separate. And many times we do see patients who come with hyponatremia during treatment. It's probably as a result of SIADH. It can happen in many patients who present with sepsis. It can happen with chemotherapeutic agents. It can also happen with brain tumors. So all of this can cause hyponatremia and it can be life-threatening. And finally, among infections and cytopenic complications as well. So how does superior mediastinal syndrome? So in the next few slides, we will see on how we can spot a oncological emergency fast. How do you think of cancer and how do you act on it before, as in how do you stabilize the patient before you refer? So spot fast in a patient who comes with respiratory distress, fast breathing. So it's very easy to say that patients to spot it because as people who treat cancer, for us, this is probably very common, a patient who comes with all these symptoms. But for a primary care physician or a pediatrician who's encountering respiratory distress in many more other conditions other than cancer, how do you identify cancer and how do you differentiate it from the usual common reasons for respiratory distress, like, for example, a bronchiolitis or a viral respiratory infection, etc.? So that is the catch. So patients coming with fever, fast breathing, respiratory distress, with nodes in the neck, mediastinal obstruction features like plethora, congestion of the face, etc. And if you have had a chest test, it shows you like this. If it's showing you mediastinal mass or pleural effusion, here you can even note the tracheal narrowing as well. So the child might be coming to you with stridor. So these are red flag signs. If a patient is aggressive course, quickly progressing, if there are lymph nodes, if there is leukocytosis, and a very useful tip is high uric acid in your blood screen, biochemical evaluation. So these are very good red flag signs to pick up a malignancy earlier. So cannot be infection. This cannot be tuberculosis. And why I'm emphasizing tuberculosis is something which we commonly see in many resource-limited or low-income settings. And many times patients get started on tuberculosis empirically. Many times even steroids are given empirically, thinking that this is tubercular pericardial effusion, and that can actually delay the diagnosis of a cancer. So how do you act in such a scenario? Get to a diagnosis in the least invasive way. So find a way to get some fluid tissue out to get a diagnosis. If you have it in your CBC, if your total counts are very high, it shows blasts, then that's probably the easiest way to get to a diagnosis is a bone marrow aspiration or even a flow cytometry on peripheral blood. But if you do not have that, if it's just a lymphoma or a mass and it's not yet in the bone marrow, you cannot get to a diagnosis from a marrow, then a pleural tap perhaps. There are some non-invasive tests that we'll see, and probably a lymph node biopsy can also help you quickly. Important things are put the cannula in the lower limb, secure the cannula in the lower limb because the circulation in the superior vena cava system is already congested. You don't want to put in more fluid through that. Keep the child proper, oxygen, potassium-free fluids, refer early. So this is how you would evaluate and quickly stabilize and manage a child with superior mediastinal syndrome. What happens to children who present with brain tumors? Again, common symptoms, headache, vomiting, maybe one odd neurological symptom, for example, like a squint or maybe diplopia, these kind of features. A lot of children present with early morning headache and vomiting. So this can be due to a whole lot of conditions. With the screen time today, which a lot of children are constantly glued to their screens, so that can cause headache. Refractory errors can cause headache. Vomiting can be because of gastrointestinal issues also. So from all of this, how do you tease out brain tumors? Early morning headache, vomiting which relieves headache, and probably neurological event like new neurological findings. Very, very urgent to get an MRI brain, get a neurosurgery opinion, and send the child to a center where there is a neurosurgeon capable of doing shunting, biopsy, because all of these are going to save the life of that child. If you do not act at that point of time, if you wait, if you start steroids and wait, that can be often life-threatening. And or at times, maybe the tumor becomes so big that you may not be able to remove it properly, or there will be a lot of neurological sequelae later. So early diagnosis and early referral would be required. And by the time you have a tissue out, biopsy, and then start treatment, many of these malignancies can be taken care of. So this is again a picture which shows you a child. So this kind of presentation, early symptoms will be there, and so act upon a vomiting which is coming to you with headache and vomiting which is relieving headache. Very important to think of patients presenting with brain tumor. What about spinal cord compression? Spinal cord compression, if there are masses in the spine near the posterior mediastinum or the retroperitoneal area, if they compress the spinal cord, they can present with neurological symptoms. So at times when they start off, it will present only with bowel and bladder symptoms like dribbling of urine, constipation, etc. There may be just sensory pain in the sensory issues in the legs like tingling and numbness in the legs. And after a while, child says, I'm not able to walk. If it's a small baby with neuroblastoma, for example, the parent is noticing that the child is not moving the leg properly. And a lot of times it can be also backache. So lumbar pain in a child is never normal. Anytime a child comes with a lower backache, always evaluate. Many a times it is a hematological malignancy per se, like leukemia, and at times it can be a spinal cord tumor as well. So the biggest thing is, again, in a setting where tuberculosis is endemic, the first thought process for any new onset neurological symptom is let's do a lumbar puncture, let's do an MRI. Maybe this is tuberculosis. There will be some pleocytosis in the CSF, protein will be high. So many children get empirically started on ATT even without a microbiological proof. They get started on steroids and then that delays the whole process. So there are a lot of malignancies which can present with spinal cord compression, which includes neuroblastoma, Ewing sarcoma, lymphomas, and even spinal cord tumors. So if there is an associated abdominal mass, if there is hypertension, if there are bony or soft tissue lesions, which you can say lymph nodes, any of these symptoms, always, again, any paraplegia, definitely you need an MRI. In addition, you need to identify where that mass is coming from, and at times you need a CECT of the abdomen as well to identify the retroperitoneal lymph node complex or a mass which is there, which has a dumbbell extension into the spine. Now, how do you proceed? You have a patient like that with you with a compression. By the time you arrange for transfer, definitely in these patients, since lymphoma is lower on the cards, it's usually neuroblastoma, Ewing's, etc. that presents like this. Here, you may even for the immediate reducing the edema in the spinal cord, you can start steroids. Do a biopsy if possible. A core biopsy is usually possible in many centers, and start treatment for the underlying. By the time you stabilize and just speak to your tertiary care center and start managing. Many times, even one dose of chemotherapy can shrink the mass quickly and it can reduce the further damage to the nervous system. And many times, if you act early, the neurological issue is completely reversible. So the tumor shrinks, the edema shrinks, the pressure on the spinal cord is relieved, and as a result, the symptoms can actually can be completely relieved. If you have a good neurosurgeon at your center, even laminectomy is possible. You can just immediately reduce the pressure and reduce an impending complete paresis in this patient. So this is again a picture which shows you a mass which is actually getting into the spinal cord and causing paraplegia. So quick action here again. So spot it fast, think that it could be cancer, and act now. So that is the whole motto behind picking up patients with the oncological emergencies. Tumor lysis, again, we'll see it in a bit, but any aggressive malignancy can cause tumor lysis. Does tumor lysis present with symptoms? Unfortunately, no. By the time there are symptoms, it is usually too late. Symptom is only renal failure. Symptom is only cardiac arrest. So you don't want to wait for either of those things to happen. So anytime when you have a patient with lymph nodes, with high counts, always look at uric acid, hyperkalemia, hyperphosphatemia. So potassium, uric acid, phosphorus, if it is high, then this is tumor lysis. Start hydration immediately, double maintenance fluids, give aggressive diuresis with furosemide, monitor renal function electrolytes. So how do you manage potassium? How do you manage phosphorus? All of this will be dealt in a while. And many a times we add allopurinol upfront for our patients to prevent tumor lysis. And if there is evidence of hyperuricemia, we add rasburicase, which brings down the uric acid quickly so that it does not cause further renal dysfunction. So again, tumor lysis in all aggressive malignancies. So majority of pediatric malignancies are aggressive. So we would see it in leukemias, we would see it in lymphoma, Burkitt lymphoma especially. You would see it in few of the solid tumors also, which are quite aggressive. Then coming to the cytopenia group of emergencies, the febrile neutropenia, bleeding and severe anemia. Febrile neutropenia, any fever in a child with cancer is an emergency. So never send the child back without consulting a particular. So if it's a biggish hospital, general hospital where there are other departments also, if a child is coming to you to an emergency with a diagnosis of cancer and fever, or with a fever and neutropenia in your CBC, always think that this can be life-threatening. The neutropenia could be at the diagnosis itself. You may have a WBC count of say 300,000, but the functional neutrophils will be very low in that. That might be just lymphoblast. And so even if you have a very high count, if you have neutropenia and if you have fever, that is life-threatening, always start antibiotics quickly. Do not think that this is a routine infection. Let me call tomorrow morning. So that doesn't work. 50% mortality if we do not treat febrile neutropenia on time. And so neutropenic patient, always look for abdominal symptoms, hypotension, patient who presents with a patient who presents with hypoalbuminemia, hyponatremia, all of them are going to be very sick. And immediately send blood cultures. No, imaging does not really help. An X-ray or a ultrasound generally does not help us in the first go. So you always send counts, biochemistry, blood culture, immediate antibiotics, and early aggressive antifungal therapy. And majority of these children, if we do not act immediately, we may not be able to salvage the life of the child. Thrombocytopenia, again, patient with you having mucosal bleeding or a neutropenic child having headache, altered sensorium, bleeds in the mouth, severe anemia, oozing from venipuncture sites. Always act immediately. Any mucosal bleeding is life-threatening. Patients who present with hematuria, GI bleed can lose lots of blood. And again, you need to act immediately and give them platelets in these patients. So many times, a lot of malignancies can have coagulopathy along with like PT, APTT will be prolonged, fibrinogen will be low. So you need to look at that as well. And at peripheral smear also to rule out acute promyelocytic leukemia. So this APML children are going to come with disseminated intravascular coagulation as the clinical presentation. They're going to come with fever, cytopenias. No, not much of hepatosplenomegaly. So nothing to really guide us that this is a leukemia, but an astute pathologist can tell us that there are promyelocytes. And if you have a DIC kind of scenario, act immediately. So my key messages are oncological emergencies are often the first presentation of a cancer. So do not miss it. So if it's lymphadenopathy, if it is high uric acid, if it's headache, so all of these symptoms are to be considered as emergency. And you need to act immediately. And early recognition by a frontline clinician is very critical to saving the life of the child. Key message 2, think cancer whenever you have an unexplained symptom like unexplained fever, persistent headache, progressive symptoms like progressive respiratory distress. Whenever you have this, always think of cancer as an underlying diagnosis. Red flag signs include persistent fever, rapidly enlarging nodes, bony pain, backache, headache, respiratory distress, etc. Key message 3, common pediatric cancers drive most emergencies. So you don't think about unusual. So leukemia, anemia, bleeding, hypoleukocytosis, tumor lysis. So these are the emergencies that we need to be worried about. Febrile neutropenia. Similarly, brain tumors, new onset neurological issues like seizures, raised intracranial pressure, always think of underlying brain tumor. 4, always be aware of airway and circulation, because if you're going to stabilize and send the patient, be aware that if you have a mediastinal mass, you need to be cognizant that you need to secure the airway. Don't make the child lie flat. Supine position can increase it. Do not sedate the child. Always keep the child propped up with oxygen, cannula in the lower limb, and a fluid running without potassium or calcium before you refer the patient. No sedation, no unnecessary biopsies, no empirical, as in at times you may have to give empirical steroids, but if you're going to plan to treat the child, get a biopsy quickly and then start steroids, and judicious transfer. And final key message is early referral saves lives. So this is it's a poster which we have prepared. on the occasion of ICCD 2026, Spot Fast, Think Cancer and Act Now. So recognizing early, referring early actually saves life. So suspected cancer, and if you have an emergency, stabilize the child, have a licensing with a unit which treats cancer in your neighborhood, speak to them, understand the process, and give a proper referral with all the details. Do not just ask them to go to that hospital, because there may not be anybody sitting there to immediately take care of the child. So plan a shifting, plan a referral, and then send the child, and this can actually save lives. So I'll stop here, and this is our team, and I thank them for all the emergencies which we have been able to manage so far. And I hand it over to Dr. Rula Farah. She'll be discussing the panel discussion. Could you share the slides from IPSI?
Can you see my slides?
Yes. So I'll introduce you, Dr. Rula, first. Could you put your slide first? Yeah. So the moderator is Dr. Rula Farah. Dr. Rula is Professor of Pediatrics and Pediatric Hematology Oncology at the Lebanese American University and the LAU Medical Center, Ritz Hospital. She holds a global MPH from Imperial College London and is US and Belgium board certified. A clinician scientist specializing in rare bleeding disorders and childhood cancers, she founded CHANCE, which is Children Against Cancer, and has led many initiatives with Childhood Cancer International, or CCI, the World Health Organization, and SIOP-Asia in advancing pediatric cancer care globally. So over to you, Dr. Rula.
Thank you, Nita, for this nice introduction, and thank you for our panelists, Talia Ahmed, Dr. Rawad Rehani, Dr. Mukesh Dankar, and Dr. Miguel Aboud. We'll be discussing specific cases of oncologic emergencies with very educational material. Our first panelist is Dr. Miguel Aboud. He's a professor of pediatrics. He's a medical director of the Children's Cancer Center of Lebanon at the American University of Beirut. He has had senior academic and leadership roles at AUBMC for over 2 decades. He has been the chair of the Department of Pediatrics. He is also an affiliate professor of pediatrics at the Medical University of South Carolina. He's an internationally recognized expert in pediatric hematology, oncology, and hemoglobinopathy, especially sickle cell disease. He has held leadership positions in major global organizations, and his work has significantly contributed to advancing pediatric cancer care and blood and marrow transplant in Lebanon and internationally. We are very honored to have you here, Dr. Aboud, discussing oncologic emergencies, specifically in children, a life-threatening one, which is mediastinal masses, how to do a rapid recognition and timely action. The floor is yours. Can you share your slides? Or would you? Dr. Aboud?
Rula, I have my slides on the screen, but I can't move them.
Okay. I will stop sharing so you can share yours.
Okay.
Go ahead.
And thank you, Rula. Thank you, Nita, for organizing this, and thanks to the IPA. You know, what I will do is, this actually was prepared by one of our third-year residents, and we had prepared a very good 1-hour talk for general pediatricians, but I will give only the part that we gave online about a month ago. And so I will just present the mediastinal masses. So, you know, these are the statistics on childhood cancer, that they are the major cause of death worldwide. And with increasing disease and we have, with the treatment of cancer and with the increased diagnosis and population, increased disease and treatment-related complications. We already talked about mechanical, metabolic, hematologic, and infectious complications, hyperleukocytosis being an important hematologic complication. But I'm going to talk about the mechanical, mainly the mediastinal masses. So this is the first case. It's a 17-year-old who presented with cough, tachypnea of 1 month duration, not improving on antihistamine, and even when the doctor, his doctor prepared him with steroids. He had cervical lymphadenopathy. He had night sweat, fatigue, and weight loss. And you can see here that there is a large anterior mediastinal mass. I don't know if you can appreciate it, not much narrowing of the trachea. At least on the chest X-ray, but if you do the CT scan, you can see that this is a very large anterior mediastinal mass. Still, the bronchi here are open. He had a supradiaphragmatic lymph nodes in the neck and mediastinum. He had superior vena cava syndrome, also compatible with bulky disease, and superior vena cava syndrome is swelling of the face and conjunctiva. So here is a question which is rhetorical. I know people will not be able to answer it, but what would be your first part in the management? Start biopsy of the mass, surgical resection, radiation therapy, or to start steroids. And you're going to see that there might be more than one answer to this question. So in this case, we did an ultrasound-guided biopsy of a supraclavicular lymph node located right here. I don't know if you can see my arrow, but the diagnosis was a large B-cell lymphoma. And of course, this is a PET scan. And this is, again, another case of a humongous left-sided superior mediastinal mass, again, with occlusion of the distal part of the trachea. These are fairly common in children. There is a risk of cardiopulmonary compromise. And if you see these masses, 7 to 75% of them are malignant. Most of them are lymphoblastic lymphomas present with a mediastinal mass. And we have to look for localization, age, and tumor markers to make a differential diagnosis. And you have the prevascular space in blue, thymic lesions, lymphomas, and leukemias. The visceral space here in yellow, which are lymphoma, metastatic tumors, cardiac tumors, and esophageal tumors, which are rare. And we have the paravertebral tumors, neurogenic tumors, neuroblastomas, nerve sheath tumors, and sarcomas. Now, how do these patients present? And this is something that you have to keep in mind. Respiratory symptoms mimicking upper respiratory tract infections or asthma. They can be asymptomatic, can be insidious if the growth is slow, and can be seen at any age in children and adolescents. And you need to keep the broad spectrum of the diagnosis in mind. And the superior mediastinal syndrome, obstruction of the airways and great vessels, compression of the trachea and bronchi. And once you have more than 30% compression, there is a grave risk of complete obstruction. And these are associated with these anterior masses with lymphoma, T-cell ALL, germ cell tumors, and some sarcomas. Again, keep in mind the tumors: cough, dyspnea, wheezes, and respiratory distress with upper airway, with upper exclusion, decreased pulmonary perfusion, right heart failure, compression of the vena cava, facial edema, cerebral edema, and thrombosis, and pulmonary edema, and low cardiac output. What are the initial measures? ABC. We need to definitely have these patients move to a high dependency unit like an ICU, elevation of the head of the bed in the prone or lateral positions, IVs in the lower limb. Do not force these patients to lie flat. Optimize the fluid status. Now, the gold standard is a CT with contrast, but this may not always be available. As you saw, a chest X-ray can be good enough, but the CT will allow you to look at the degree of vessel and tracheal compromise. Echocardiography, if available to you, is important to rule out tamponade, adequacy of blood flow, and cardiac function. Then establish a diagnosis. Flow cytometry on peripheral blood is, if there are blasts, will save us a lot of problems. If there is a pleural effusion, a quick tap with the patient in the sitting position might allow us to make the diagnosis of lymphoma cells. Look for tumor markers, LDH, beta HCG, alpha fetoprotein, and of course, for staging, once this is out of the general pediatrician's hand, a PET scan is going to be needed. Biopsy, preferably of the extra mediastinal mass, more amenable to biopsy. Image-guided transthoracic is less invasive, but it's important to have a multidisciplinary approach. This is a pathway. I'm not going to go through all of this, but if the patient has orthopnea, stridor, or obstruction, one needs to look for alternative tissues. If they are not available, then one needs to go to an alternative way to get a biopsy. Avoid general anesthesia and sedation, and muscle relaxants are to be avoided. Patients need to be on spontaneous breathing. Positive pressure ventilation could be avoided. And why do we do this? Loss of muscle tone can lead to airway collapse and reduced preload. So whatever you do, keep the patients in the semi-sitting position. Do not force them to lie down. Do not accept anesthesia for the biopsy unless you have moved them to a tertiary care setting. Even in that setting, we prefer not to do it. This is a risk classification. And again, tracheal compression, great vessel compression, and tamponade and orthopnea usually indicate very high risk. Now, how do we manage these cases? You know, if you are in a setting where you do not have an oncologist available, it is recommended that one try 1 or 2 or 3 doses of steroids. This will not mess with the diagnosis. It will increase airway edema. And if it's a leukemia or lymphoma, it might shrink the mass. If this doesn't work, okay, but again, if you do try steroids, you have to be very careful to monitor for tumor lysis syndrome. Now, if steroids don't do it, chemotherapy usually with vincristine, cyclophosphamide, and an anthracycline might be the next step. Honestly, I prefer, if we have no response, to use palliative radiation therapy, especially if there is significant airway compression and we do radiation to one part of the mass, leaving the rest available for a biopsy. But again, this should be done only, you should refer the case promptly, and this would save everybody a lot of problems. And I will stop here and be ready to take any questions at the end.
Thank you so much, Dr. Aboud. It was very clear. And most importantly, the message related to pediatricians is when you suspect a mediastinal mass, be very careful with conscious sedation. Even dormicum can put a patient into collapse if they have compression of the airway. So that's a very important messages. You covered everything. Please type your questions in the chat and we will be happy to answer them. Now I will share again the slides to have the next speaker, which is Dr. Mukesh Dankar. Dr. Dankar is a professor at the Division of Pediatric Hematology and Oncology at Kalawati Saran Children's Hospital in New Delhi. He has extensive academic and clinical experience in pediatrics from leading medical institutions in New Delhi and Rohtak. He's committed to advancing pediatric hematology and oncology through patient care, teaching, and academic leadership. Thank you so much for sharing your experience on a very common problem, which is tumor lysis syndrome and metabolic complications. Dr. Dankar, would you like to share your slides or shall I share them myself?
Ma'am, you can share.
Okay, sure. Please go ahead.
So, can we have full PowerPoint presentation, ma'am?
Yes.
Next. So I'll take you through a case journey and then we'll talk about what is tumor lysis syndrome. So we have a 7-year-old boy. He has fever and pallor for 3 weeks and progressive abdominal distension. Generalized lymphadenopathy is also observed. And on examination, he has severe pallor, massive hepatosplenomegaly, respiratory rate is slightly on the higher side, and BP is normal. On investigation, salient investigation showed that the HB is on the lower side. TLC is high, 1,45,000. Platelets is low, 45,000. On peripheral smear, we have lymphoblast. And serum creatinine and uric acid still now are fine. So we reached to a diagnosis of acute lymphoblastic leukemia. High risk, we'll see why we are leaving it at high risk from TLS point of view. Next. So my question is this child at risk of TLS and what preventive measures are required before chemotherapy? Next. Before we answer these questions, let me take you through this journey of tumor lysis syndrome. It's an oncological emergency in children. Next. Next, yeah. So what is this? What is this tumor lysis syndrome? It's a life-threatening metabolic emergency due to rapid breakdown of malignant cells, which results in hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, and it can also lead to acute kidney injury, which can be spontaneous or post-chemotherapy. Next. So what is the pathophysiology? So as there is rapid turnover of malignant cells, these cells, when they lyse, they release potassium, phosphate, nucleic acid. And because of this, the renal excretion is overwhelmed because of these metabolites, which can lead to arrhythmias, seizures, or renal failure. Next. Next slide, please. Right. So what are the tumors in which we are at the risk of tumor lysis syndrome? So we can categorize them high risk, intermediate risk, or low risk. So high risk are the malignancies are like Burkitt lymphoma, when an acute lymphoblastic leukemia where the TLC is more than 1 lakh, when we have AML where the TLC count is more than 50,000. Intermediate risk are the ones like ALL with a TLC count between 50,000 to 1 lakh. DLBCL. Low risks usually we see in Wilms tumor, neuroblastoma, germ cell tumor, where though we can see TLS, but we see less commonly. What can be the other predisposing factors? It could be the tumor factors, host factor, or the aggravating factor, depending on the kind of burden of the tumor, large tumor size, or if we have a young child, or the kidneys also compromised prior because of the nephrotoxic drugs or renal infiltration by the tumor. Next. So, how do we classify TLS? So, we classify into two types, laboratory TLS or clinical TLS. Laboratory TLS is when we have 2 or more lab abnormalities within 3 days before and 7 days after therapy. If we see a uric acid of more than 8, potassium of more than 6, phosphate of more than 6.5, calcium total of less than 7, or ionized calcium less than 1.12, and we call it as a clinical TLS if along with laboratory TLS we have any more thing like acute kidney injury, or in cardiac issues we can have arrhythmias or death, or in neurological we can have seizures, but we don't need to wait for all this. We need to preemptively take steps. So what could be the clinical features? Though usually they are asymptomatic, but we can see nausea, vomiting, muscle cramps, and if severe clinical TLS is there, seizures, arrhythmia, oliguria can be seen. Next. So how do we manage? So the first and foremost is early identification, aggressive IV hydration, electrolyte monitoring, uric acid control, and renal replacement therapy when required. So overall, I would like to say for TLS, prevention is better than treatment. Next. So hyperhydration is the cornerstone of the management of TLS. IV fluid from 2 to 4 times of the maintenance, depending on the type of tumor, the age of the child, the renal status, and everything we have to give. The aim of this giving hyperhydration is to maintain a urine output of more than 2 to 3 ml per kg per hour. We should ideally start 48 hours before the chemotherapy, but at times we may not be able to always implement that. And when fluid which we are using is always potassium and calcium free. Next. So if there is an electrolyte imbalance, if there is hyperkalemia, we need to continuously monitor ECG. We can use calcium gluconate, insulin with dextrose, salbutamol nebulization, sodium bicarbonate, and dialysis if refractory. Next, hyperphosphatemia and hypocalcemia. So We treat hypophosphatemia, but not calcium unless symptomatic. For hypophosphatemia, if we increase hydration, if we use phosphate binders, we are usually able to manage. If severe dialysis may be needed, and hypocalcemia only needs to be treated if there is seizure, tetany, or arrhythmia. Next. So coming on to the management of hyperuricemia, usually we use allopurinol in the dose of 10 milligram per kg per day in 3 divided doses. But if severe life-threatening clinical, we use resburicase from 0.05 to 0.2 milligram per kg IV. But we have to be cautious that it is contraindicated in G6PD deficient patients. Next. Next. Right. And we may also need to do some chemotherapy modifications, like phase chemotherapy in high-risk patients. For example, steroid pre-phase, which we usually give in low-income, middle-income countries, and which prevents. Now, coming back to our case, next slide. We have to, yes. So in our hospital course, we started on IV hydration. PRBC transfusion was done as the HB was only 5. Chemotherapy was initiated, which was a pre-phase chemotherapy, but 24 hours later, the child had vomiting, reduced urine output, and ECG showed peak T wave suggestive of hyperkalemia. Next. There is one, yeah. So we repeated the lab. TLS, the potassium was high, phosphate was high, calcium was low, uric acid was high, creatinine also increased. So we had a diagnosis of clinical tumor lysis syndrome. Next. So as I had discussed, we increased intensified the hydration. We gave calcium gluconate. We gave insulin plus dextrose. Resburicase was administered, and what we had, the urine output improved, electrolyte normalized, and dialysis was avoided, and we could continue the chemotherapy safely. So I would like to summarize: tumor lysis syndrome is a predictable and preventable. We should be able to identify the high risk children early. Hydration is the cornerstone. Resburicase has transformed our outcomes in the TLS cases, and dialysis can save life when needed. Thank you.
Thank you, Doctor. Now we please don't forget to put your questions through the chat. I think it was very clear. Thank you so much. We move on to the next panelist, which is Dr. Alia Ahmad. She's a professor of pediatric hematology and oncology at the Children's Hospital of Lahore. She has over 2 decades of experience in pediatrics. She has held progressive academic and clinical roles, including senior registrar in pediatric hematology oncology and associate professor, assistant professor. She had intensive work in Pakistan and Malaysia with a strong background in maternal and child health, community pediatrics, and pediatric oncology. She is dedicated to clinical excellence, teaching, and the advancement of pediatric hematology and oncology services. We are really lucky to have you with us, Dr. Ahmad, talking about tumor lysis again. No, that was your case.
No, thank you so much, Dr. Rula. My case is headache and vomiting.
Right. Maybe you can...
I can start. Thank you so much for having us here. We are very thankful to IPA. And I'll be describing about when a child has severe headache and vomiting, and his diagnosis is mistook. I cannot see my slide. I'm just talking to save time.
Would you like to share your slides?
No, I don't think so.
We share them ourselves.
I wait for you to. So any child from young age to 18 or young adults also, if they complain sudden onset of severe headaches and then early morning vomitings, many of them continue to be treated for migraine and gastrointestinal problems until it's too late and the tumor gets bigger and bigger. So for pediatricians and general physicians and doctors who are taking care of children, I think we have to tell them that headache and vomiting is very ominous symptoms, and we have to keep in our minds that it can be brain tumor, because in many cultures it's a stigma. So brain tumor is also like it's a very serious illness. So people, doctors, especially healthcare provider, they don't think about it that a simple vomiting or simple headache can be brain tumor. So we have to keep in our minds that any child who comes with headache and vomiting, we have to think about brain tumors. Otherwise, it can be too late and can cause severe disabilities and mortality also, as previously described by Dr. Neeta in her presentation. Yes, thank you so much. So the first slide, you have to go one slide back.
Yeah, sure.
Thank you so much. So
Please go
just a
ahead.
small case, yes, thank you so much. Just a small case scenario that a 5-year-old boy presented in the pediatric medical emergency with a 4-week history of headaches, treated with analgesics off and on, and then he started having early morning vomiting since last week. No diarrhea reported. Parents noticed that he has been less active, and his teacher also noticed him less engaged in the kindergarten. When the MRI was done for his these complaints, he had a huge infratentorial posterior fossa tumor. Next, please. So, brain tumor, they cause intracranial pressure because of the obstruction of CSF flow and also the direct compression of brain tissues. So initially they have very non-specific symptoms like fatigue, intermittent headaches, personality changes, school performance is changed, and loss of skills. But then later, when the tumor gets bigger, they have morning vomitings, unremitting headaches, and cranial pulses, nystagmus, and so on. The symptoms continue to get worsened depending on which area of the brain is involved, supratentorial or infratentorial. So it's very important that we keep on disseminating the information. Like in UK, they did a Head Smart campaign where the lag time for diagnosis of brain tumor was in months, but when the GPs and their healthcare providers in the peripheries were taught and trained for symptoms of brain tumors, then this time lag decreased from months to weeks and even days in many areas. So I think it's our duty that we keep on telling our colleagues that don't take it light, that if a child comes with headache and vomiting, because neurosurgical intervention is needed urgently, by that time we give them dexamethasone and normal saline fluids. Next, please. In the same time, when we have to tell our colleagues about brain tumors, and we need to tell them, and we have to disseminate information about the backache. Backache is not a very good symptom, because if the child complains, parents think maybe he's tired, he was too playful, and it can be due to that. But we have seen many cases where backache was the only sole presentation symptom for a child, and parents and the physician didn't believe the child that this backache is serious. So just as this scenario, that 8-year-old boy, he experienced back pain. He was evaluated by a family doctor. CT didn't show anything. Then leg pains intensified, and they consult a neurologist. He had severe leg pain, so MRI was not done, just to soothe the child. And then when the symptoms continued and worsened, then MRI was done, and you can see that there's the brain, the spinal tumor is there, which is invading the spinal canal also. Next, please. So for children, they have a spinal tumor. They can present 3 to 5% of children with cancer have spinal tumors, and they have very diverse range of cancers. Any type of tumor can be there in the spinal canal. So for solid tumors, our first differential is neuroblastoma in young children, and Ewing sarcoma can be of any age, and hematological malignancies is also can be there, but where maybe their CBC can help us there, but sometimes there is nothing in the CBC, and their children only present with severe backache. And then the brain tumor, whether primary or metastatic tumor, should be in our mind. And MRI is critical for diagnosis. Some people prefer CT scan, but I think MRI with contrast is is a preferable diagnosis tool. Next, please. So back pain is very important to have us in our mind that if a child presents a backache, it can be due to spinal tumor, because 80% of patients of spinal tumor having spinal tumor with cord compression, they present with back pain, and then the neurological signs develop with weakness, paraplegia, paresis, quadriplegia, urinary and fecal incontinence, and prognosis is based on the level of disability and duration of symptoms at presentation and diagnosis. As Dr. Neeta also mentioned previously that the time is very important for spinal cord compression cases, because we have to keep in mind that earlier we diagnose, earlier we take action, we can save them from permanent neurological signs and symptoms. So for hematological malignancies involving the spine, we give chemotherapy, surgery for solid tumors like neuroblastoma and Ewing sarcoma, and for spinal tumors which are very common like ependymoma or glioma, we do surgery and radiotherapy. So the take-home messages for us is any child who presents with severe headache, vomiting, or backache, please look into, just keep in mind that it can be brain tumor or spinal tumor, and the time is very important. So earlier we do the diagnostic tools, and this is simple one test, MRI brain and spine, which can save the child and prevent him from getting severe permanent disabilities, even morbidity and mortality. Thank you so much.
Thank you so much. So I hold the very important tips, which are back pain in children is never normal. Always think of something happening, a tumor happening in the spine with compression. Also, very important to be very quick, because the spinal cord is not made to tolerate any compression, and any compression will compromise the long-term outcome of the child. So being rapid in identifying these cases is very important. And now we move on to our next speaker, which is Dr. Rawad Rihani. Dr. Rihani, I'm going to share my screen here. Great, and then the slides. So Dr. Rawad Rihani, we are so honored to have you here. She's a consultant pediatric hematologist oncologist at King Hussein Cancer Center in Amman, Jordan. She's the chairperson of the Department of Pediatrics. She leads the Pediatric Blood and Marrow Transplant and Cellular Therapy Program. She is the president-elect of the POEM Group and the former president of the Jordan Society for Pediatric Oncology. She's an associate professor at the University of Jordan, and she holds advanced training in pediatric hematology, oncology, and BMT, and fellowship experience in Sydney, Australia. She focuses on pediatric cancers, blood disorders, transplantation, and global child health. We are very happy to have you with us talking about fever and neutropenia. I will share your slides in 1 second here.
If you like. Thank you, Dr. Rula. Thank you, IPA, for this great initiative. It's truly an honor to be with you today. I can share my slide if you like.
Whatever you prefer. Yes, I'm ready.
It's fine.
There you go. Can you see my screen?
Yes.
Yes. Okay. Okay, Dr.
If you
Rihani,
just can put them in the slideshow.
Sure. Go ahead.
Okay, so I think this topic is very important. All of these topics are very critical to the care of children with cancer. And equally, all of them are very important to recognize. Can you move the slide, please? Today we're talking about febrile neutropenia, which is in children. There are a medical emergency. So any child with cancer who has fever is a child with emergency. So I cannot see the slide, the Rula, it's not moving.
Wow. Can you see now?
I can see it, but it's not moving. So if you, I can share it myself if you.
So go ahead. Yes, please share it yourself. Yeah. I stopped shared. Please share your slide. It's better. In the meantime, we have a question Thank you from Paromita Hossein. Thank you for the nice presentation on TLS. Shall we give packed RBCs first, or after ensuring proper hydration, we should transfuse packed RBCs? Would you be able to answer this question, please? Shall we give packed red blood cells first or after hydration?
So I can take it. It depends on the tumor, the WBC count. If your WBC count is very high, we generally avoid a packed red cell transfusion immediately because it increases the hyperviscosity chances of thrombosis. So otherwise, if your counts are low and you started on hydration, etc., your regular usual cutoff for transfusion will be the same. So in a patient with active cancer, it will be hemoglobin of 8 gram per deciliter. That's what you will see. So if it's less than that, you can transfuse the patient. But if say the WBC count is like 300,000, so even at 7 grams or 6 grams, you generally would not give packed red cell transfusion at that point. You will wait for the counts to come down and then only transfuse. I hope it answers your question.
Sure. Sure. Dr. Rihani, please go ahead.
So I've got a case of a child, just an example, a child with 6 years, who's 6 years old with acute lymphoblastic leukemia, who's receiving induction therapy. As you know, this is the most intensive chemotherapy phase of treatment. And this child presents with the emergency room with fever for 3 hours. So this temperature was about 38.6. His heart rate is 132 with blood pressure of 95 over 55 and the respiratory rate of 28, saturation 97%. And this child has received the chemotherapy 5 days ago. He has a central line and he appears to be tired but responsive and no obvious focus for infection on the examination. So typically, does this child meet the criteria for febrile neutropenia? So we need to recognize that this is definitely a febrile neutropenia case. And this is definitely the case since it's fever more than 38.5, although it's one temperature, but anything above 38.3 is a significant fever. This child has received chemotherapy. So we should assume, don't wait for the count to come back. You should assume that this is neutropenia until proven otherwise and consider this to be a medical emergency. So what is febrile neutropenia? It's a fever more than 38.3 that occurs once or any 38 spaced by 1 hour that's persistent, more than 1 hour is a significant fever. An ANC of less or equal 500 or expected neutropenia to be on the way if the child just received chemotherapy or if the child has functional neutropenia, as mentioned earlier. Sometimes the count is normal. However, we know that the neutrophils are not working properly in this child since he has leukemia and he has chemotherapy. So it is a common complication of chemotherapy in children with cancer. It is a medical emergency until proven otherwise. It is common, so we see it up to 40%, sometimes more, in children who received chemotherapy or those with cancer. And we see it in more frequency and also in higher risk in children who have acute leukemia, lymphoma, or non-Hodgkin lymphoma in particular, and recipients of bone marrow transplantation. We see it in less frequency and less severity in those who receive maintenance chemotherapy. However, this is like not written in stone. So what happens? Why does it happen? So most common infections are bloodstream infections are the commonest identifiable cause. And historically, we have seen a shift from gram-negative to gram-positive. And nowadays, there's a resurgence of gram-negative bacteria in patients who have neutropenia. So the current trend really right now are more gram-negative bacteria, especially E. coli predominance. But however, this changes with biogram change change for each hospital, depends on the antibiotics, depends on the patient population. And there's also rising rates of multi-drug resistant organisms that we see in cancer patients. Fungal infections are also very important, and there's increasing concern, especially if patients have prolonged episodes of neutropenia. And most common bugs that we see are Aspergillus and Candida, and they should be covered in cases where we have prolonged neutropenia and prolonged fever. In many episodes of febrile neutropenia, the pathogen is not identified, and there's also increasing, incidence of viral infection recognized to cause infections in febrile neutropenia patients. So what is the immediate priority? What is the most important thing and action to do in the first hour? So every single patient who have fever and cancer is a medical emergency and should be treated regardless of the underlying pathology. So you need to start broad spectrum antibiotics within the first 60 minutes of presentation. And we should not wait for checking. We should send the blood count. However, you don't need to check for the ANC, the blood culture result, or the imaging, although we need to do them. However, the first single most important action to do is start broad spectrum IV antibiotics as soon as possible. Why is the case? Because it is a leading cause. Febrile neutropenia is a leading cause of treatment related mortality. And despite the advances, it still causes significant clinical challenges. And there is an incidence of 2 to 6% of mortality related to febrile neutropenia. And in the majority of cases, those deaths are preventable. So this is a preventable cause. Just by starting a broad spectrum antibiotic, you might be saving a life of patient. So early recognition in this case and early identification of bacteremia and rapid treatment are the most critical thing to do to improve the outcome and save lives. So this is what we call the golden hour, and the golden hour matters because if you delay antibiotics, your patient might go into bacteremia, septic shock, and death. So you need to start early antibiotics, early fluids, and you can save the life of a patient. So why are cancer patients at a high risk? Simply because they have impaired immune response because of cancer. They have central lines. They have disturbed mucosal barriers such as mucositis, gut translocation. They are on intensive therapy such as steroid, chemotherapy, etc. Antibiotics, again, is the single most important thing to do, and we should not delay because this improves the survival. So what are the features that place a child to be at risk of sepsis? So in general, patients who have underlying hematological malignancies, those who have just recently had within the last 7 days intensive chemotherapy, those with central line, those who are presenting with tachycardia, or they have early signs of clinical instability. So, and there are risk factors for sepsis and poor outcome that one should be aware about them, such as patients with severe neutropenia, less than 100, or they have prolonged neutropenia, those with central line, recent chemotherapy, hematological malignancy, bone marrow involvement, a CRP of more than 90, lactate of more than 3 millimoles, and those with previous history of invasive infection or septic shock are at a higher risk of having recurrence. Other factors: prolonged neutropenia, hemoglobin less than 7, low platelets, low albumin less than 2.5, high serum lactate, and low serum bicarb of less than 17. So in this patient, how did we recognize if this patient that we addressed has sepsis? What are the findings in this case? So this patient had tachycardia, tachypnea, he had some lethargy, borderline blood pressure for age. And we should also remember that hypotension in children is not an early sign. So if the patient has borderline blood pressure or low blood pressure, you should recognize that this is an advanced infection and it might be a sign of sepsis. Other signs to recognize in this child: fever of more than 39, hypotension, poor perfusion or altered mental status. These are signs of sepsis. And these are your warning signs: altered mental status, tachycardia, poor perfusion, respiratory distress, hypotension, remembering that this is a late sign in children. So in this, again, these are the important signs. To reiterate again, you should escalate treatment very early to reduce mortality. So the first action within the first hours, again, secure IV access, get the blood culture, but start both spectrum antibiotics as soon as possible within the first 60 minutes, and begin your monitoring of blood pressure and other vital signs. And remember, infection with organ dysfunction is sepsis, and septic shock. It can be a delayed sign where there's poor perfusion, hypotension. If you give fluid and the patient doesn't improve, this is a sign of septic shock. Definitely, you need an ICU involvement in early phases. So if your child the patient becomes hypotensive, although you're giving IV fluids, what are the next steps? So definitely alert the ICU, get an ICU consult, consider inotropes very early on, and upgrade your antibiotic. If the patient has received antibiotics already, they might need to get upgraded antibiotics into more broad spectrum, such as meropenem, vancomycin, more supportive care, depending on the situation of the patient. Definitely, you need to have full vital signs, focused examination to look for a focus, and assume neutropenia if there's a history of chemotherapy recently. Oxygen therapy is very important. Fluid boluses is very important. And consider stress dose of steroids if the patient has hypotension. Those children definitely, in majority of the cases, they need to be admitted, monitored, and don't delay the escalation. So the most important teaching point here, fever in a child with cancer is sepsis till proven otherwise. Early treatment saves lives. And remember, fever plus cancer is emergency. Febrile neutropenia is an oncological emergencies. Treat first, confirm later. The clinical status is more important than the lab confirmation. Systems and protocols in place. For example, if we have a standard protocol for treating febrile neutropenia, is very important rather than relying on scattered or individual measures. Also, there are very important risk stratification tools. They are important in practice. Sometimes they fail to recognize the case. So in that case, you always should treat and then stratify later. So fever in pediatric oncology is not a symptom. It is a diagnosis of sepsis, septic shock, or emerging septic shock. Treat as soon as possible and confirm later. Thank you so much.
Oh, it's disabled. Thank you so much, Dr. Rihani, for this nice presentation. You highlighted a very important point, which is the fact that indeed fever in cancer patients, in neutropenic patients, is an acute vital emergency. So now, for the essence of time, I know we have also another question. What broad spectrum antibiotic should be started is from Mughira Tahir, and what should be the deciding factor on the dose of antibiotic? If you may answer that before my closing remarks, dear Rawad.
Yes, hi. So we need to cover for gram positive, gram negative upfront. So those patients should get, it depends on your hospital biogram. So the majority of cases, they get tazocin, amikacin, or monotherapy such as tazocin. Sometimes we use cefepime amikacin. So it depends on the biogram at your hospital, but always go broad. If your patient is sick, hypotensive, and has a line, definitely you need to go into broader, such as meropenem, vancomycin. But never go for simple antibiotics, such as if your patient is sick, such as Rocephin is not enough in that case. So always choose an antibiotic that covers for both gram positive, gram negative. The doses are calculated per weight of the patient and depending on the age and of course the renal function of the patient.
Does it also depend on the sensitivities of each institution? Yes. Like, should you look at your ID people and see what they recommend?
Absolutely.
Right?
Absolutely. So for each hospital, for example, at King Hussein, we have our own biogram and we know what are our bugs are sensitive to which upfront. So we have a standard clinical protocol for us. We use tazocin, amikacin as a first line for patients. And then we escalate according to the other cultures, to the biogram of our patient, the clinical situation, the fever, the clinical response is very important in few days as well.
Great. I would like to now make the final remarks of this very interesting webinar, and it's very practical to pediatricians. So why is it important to recognize oncologic emergencies, and why we oncologists make sure that we and pediatricians are aware of all the problems that can occur? Because they can be the first sign of cancer in a previously well child. Look at this infant that appeared normal, started having all these abdominal growths and ended up having actually a neuroblastoma pushing the liver forward. They can be life-threatening. They can affect the future outcome of the child, especially if there is spinal compression or a brain tumor that is not recognized early. So emergency room physicians and primary care physicians are often at the front line and might have to stabilize the child locally before any transfer to a tertiary care or specialized center. So really this webinar gives the basic information to be able to handle any oncologic emergency, stabilizing the child, saving his life. So they are treatable, they are reversible if identified early and managed properly. As we said, in summary, emergencies can result either from space-occupying lesions and compression of vital organs, from metabolic imbalances, or abnormalities of the blood and blood vessels. And keep in mind the oncologic emergencies that we always need to remember: superior vena cava syndrome, spinal cord compression, brain herniation, hyperleukocytosis, massive hepatomegaly, coagulopathy, anemia, fever with neutropenia, and tumor lysis syndrome and hypercalcemia. So the take-home messages are: remember that childhood cancer is curable, but patients can die at diagnosis prior to being treated. And sometimes in protocols, pediatric oncology protocol, we look at survival from the time of protocol entry and not from the time of arrival in the emergency room. So we are missing these pool of patients that are dying before entering any treatment protocol. So we need to recognize oncologic emergencies, we need to act rapidly, and we need to have quick and adequate actions in our mind, which can really save a patient life. So any questions that you would like to share? Thanks, everybody. We have a great attendance. We had over 150 people registered to this webinar. This is really amazing. I would like to thank everybody in the pediatric oncology subgroup for working hard in making this webinar so successful and happening exactly on the International Childhood Cancer Day. So a tribute and a thought from all of us to the heroes, the real heroes, which are the children and the families. Please do not forget to screen the feedback form. And once you fill up the feedback form, this is when you will get a certificate of attendance from the International Pediatric Association, and then submit it to your institutions for your CMEs and credentials. And bear with us, we have a very nice schedule of talks coming up with this very active group. Any questions, Nita? Any comments? Dr. Haddad, anybody? I think it was really oncologic
Excellent
emergency
seminar, everybody.
really in a nutshell. We covered so many topics in a nutshell. It's truly amazing that we could discuss all that in a short period of time. I'm filling the form, so it was really
Thank you, everybody.
excellent.
I think with that, we'll come to the end of this webinar. We will, the link for the feedback has been asked. So we will be sharing the QR code was shared. We will share the link in the chat.
Great. So thank you all.
Thank you. And thank you until
Thank
we
you
meet
so
again
much.
for the
Thank
next
you.
webinar.
Bye-bye.
Thank you. Thank you. Thank you. Thank you, everyone.
Bye.